Hello, everyone. Welcome to my YouTube channel, where I make pharmacology simple for anyone to understand. Now, you may be someone who would like to understand how the drugs we use in people that have seizures work. If you are such a person, this video is specifically made for you. And so I would like to invite you to follow me on this journey as we look at anticonvulsants. I am Professor Kennedy Edem Kukia, and I'm happy to have you here. Now, what are anticonvulsants? Basically, they are drugs that we use in treating seizures. Drugs that we use in treating seizures. Now, these seizures could be seen in people that are either living with epilepsy or people that have certain situations that make them have the seizures. And so there are people that may not have epilepsy, but may experience seizures. And then there are people that, as a result of the epilepsy, have seizures. Now, in such people, we use these anticonvulsants in addressing the problem of the seizure. Since the anticonvulsants, one of the main uses is in epilepsy, we would want to at least understand what epilepsy is all about. So we normally say that epilepsy is a neurological syndrome, or it is a group of neurological disorders that is characterized by spontaneous, recurrent, and transitory seizures. So the main feature in epilepsy is the seizures. It is spontaneous because normally if the person is said to be epileptic, that person's seizure does not need to be provoked by anything. It is recurrent in the sense that it is chronic and something that happens over and over again repeatedly. Then it is transitory because when the seizure begins, there is a time it will stop, then another time it will continue again. It doesn't continue throughout the day. So that is why we are saying it is transitory. Now, since the main feature in epilepsy is seizures, let's try and appreciate what seizures are. So seizures are described as abnormal hypersynchronous discharge of or electrical discharge of cortical neurons. And so simply, if you have the cerebral cortex, the biggest or the largest part of the brain, there are neurons there that send signals. If these neurons are sending or firing their signals in an abnormal way, someone could have seizures. Now, it is important to also say that these neurons in the cerebral cortex, if you pick the cerebral cortex, it is divided into two hemispheres. We have the left and then the right. And so if someone has a seizure where the seizure is from both hemispheres, so let's say this is our right and then this is our left. So if the seizure is in both hemispheres, we say the person has a generalized seizure. But if the seizure is in just one hemisphere and remains there, we say the person has a focal seizure, sometimes referred to as partial seizure. But there are people that may have a seizure that starts with one hemisphere and then moves on to the next hemisphere. We say those people have a partial seizure that is secondarily generalized. Now, there are subsets of these seizure types. So for generalized, we may have what we call atonic seizures. We may have infantile spasms. We may have generalized tonic-clonic seizures. We may have myoclonic jerks. And so there are various presentations of the generalized seizures. There could also be absent seizures. When you pick the focal seizures, which used to be called partial, we may have different manifestations of them. One of them would be such that as the person experiences the seizure, the person may lose consciousness. Such ones, we call them focal unaware seizures. But if the person gets the focal seizure without losing consciousness, we say that that person has a focal aware seizures. And there is a way these would present, but for the purpose of our discussion today, we would not delve too deep into this area. Now, one may ask, if we say that the neurons in the cerebral cortex are firing abnormally, what is making them fire? Let's try and understand what is happening in the normal brain and what is happening in the epileptic brain. So first, the normal brain. If we pick the normal brain, usually some of your neurons are sending what we call excitatory impulses, and then some of your neurons will be sending what we call inhibitory impulses. And these inhibitory impulses are to fine-tune the excitation so that we don't have excessive excitation. And so in the person that has the normal brain, or the person that has the normal brain, the inhibition or inhibitory neurotransmission is supposed to regulate and then suppress too much excitation. So we will say that there is a balance between the excitation and then the inhibition. However, when it comes to the person with epilepsy, in that person, the excitatory neurotransmission is exaggerated. And so we have excessive excitation while the inhibition is reduced. And so because the inhibition is not fine-tuning the excitation, there is that abnormality that allows us to have the seizures. Now, if the person keeps on having seizures that are unprovoked, that, as we described, they are unprovoked, they are recurrent and transitory, then we say that person has become epileptic. And there are many mechanisms that could make people become epileptic. But this is not our focus for today. So if we are saying that excitation is excessive and that inhibition does not increase to cancel out the excessive excitation, we would want to appreciate the drugs that we use in bringing down the excitation whilst elevating the inhibition. Because if we want to address the seizures, then we would have to reduce the excitation while bringing up the inhibitory neurotransmission. By doing that, we'll be able to address the seizures. So first, we look at the excitatory mechanism. One of the things we look at when it comes to the excitatory mechanism is the movement of ions through their ion channels. And so we can pick a first scenario where these ions move through, like the arrow shows, it moves through the ion channels. So it could be a sodium ion that has moved into the neuron, or it could be calcium ion that has moved into the neuron. Now, these ions, when they move in, they cause depolarization. In other words, they cause excitation of the system in the brain. So by that excitation, if the amount of these ions that enter the brain are too much, then there is a possibility that the person will present with the seizures. Now, it will make sense to then say that if there is excessive influx of sodium and calcium into the brain, that is what is responsible for these seizures. Then if we want to address the seizures, we would have to block the entry of some amount of these sodium and calcium in order to address the seizures. I think it's simple enough. Another mechanism for excitation is what we call the glutamate system. Now, glutamate is one of the main excitatory neurotransmitters in the CNS. Now, when the glutamate is released from the presynaptic neuron, so it is released into the synaptic cleft through exocytosis, it binds to a variety of receptors. We have the kinase, we have the NMDA, another one is AMPA that is not represented here, or AMPA receptors, and then we have the metabotropic glutamate receptors. Now, as the glutamate binds to this, it causes excitation that then could predispose the person to seizure. So too much of the glutamate being released could cause the person to experience seizures. Now, again, it would make sense if by glutamate acting on these receptors and it causing excitation leading to seizures, it would make sense if we block the receptors on which this glutamate would bind. And usually we target the NMDA receptor or the AMPA receptor. We'll look at how some drugs do that soon. So, as we have said, the excitatory mechanisms involve the entry of sodium, the entry of calcium, and then the activity of the glutamate. Now, we would want to consider the fact that when these drugs are supposed to work, the drugs could either cancel out the entry of the sodium, and some of the drugs that we use, we call them sodium channel blockers. So there is carbamazepine, oxcarbazepine, phenytoin, primidone. Primidone is a barbiturate, but then works like phenytoin. Then we have topiramate, we have lamotrigine. We also have the T-type calcium channel blockers. An example is etosaximide, whose main use is in what we call absence seizures. In fact, it is one of the first-line drugs for absence seizures. Then we have the NMDA receptor antagonist. As we said, NMDA receptor is one of the glutamate receptors. So a drug that blocks the action of the glutamate on the NMDA receptor could help suppress the seizures, right? Now, let me also add that most of the sodium channel blockers, we tend to use them in primary generalized seizures, or we could use them in focal or partial seizures. Most sodium channel blockers, this is the kind of seizures we use them for. But we could also use them in other conditions. For some of them, we could use them in manic disorders. Some are used in pain, like neuropathic pain. Some are used in certain mood or anxiety disorders. So there are other uses for them. As I've said, etosaximide used in absence seizures, the NMDA receptor antagonist. This is not a first or even a second-line drug. Usually, because of adverse effect, we tend to use it for third-line situations. But it's quite useful in certain types of seizures. All right. Then we come to the inhibitory mechanisms. You would appreciate the fact that when we talked about the seizure, we said that either the excitatory arm is elevated and the inhibitory arm is inhibited. And so if I want to address the seizure, I may decide to target the inhibitory arm and enhance that activity. And one of the main inhibitory neurotransmitters we look at is GABA. Now, when GABA is released, like we see here, when GABA is released, it could act on GABA A receptors. Examples are the ones, different types of GABA A receptors. Then it could also act on GABA B receptors. Our focus is not on the GABA B receptors. There is also the possibility that it could act on GABA A rho receptors. These GABA A rho receptors used to be called GABA C receptors, but let's focus on GABA A. Now, if GABA binds to the GABA receptors, it would cause an influx of chloride ions. Now, as the chloride ions rush into the neuron, the postsynaptic neuron, it then causes hyperpolarization that makes it difficult for impulses to be generated. And so we are able to then suppress the seizures. And so drugs that potentiate the action of GABA could find use in dealing with epilepsy, okay, or seizures. Now, one example could be the barbiturate, which an example of the barbiturate is phenobarbital, very useful for seizures, especially neonatal seizures. Benzodiazepines could be used in suppressing seizures, but we don't use them in routine management of epilepsy. This needs to be kept in mind. An example of benzodiazepines would be diazepam, midazolam, lorazepam, and the rest, okay? Then, you see, when GABA is released, GABA can be taken back into the neuron that released them. So a transporter called GABA-T, GAT, GABA T is able to transport or take up the GABA back into the presynaptic neuron. Now, if that happens, it means that we are suppressing the amount of GABA in the synaptic cleft, and that will reduce the inhibitory neurotransmission. So it will predispose the person to seizures. So by blocking the GABA T, we are able to have enough GABA in the synaptic cleft, which will give us more or an enhanced inhibitory neurotransmission. So a drug that does that is called thiagabin. Then, lastly, we have a drug that could block the enzyme that can break down GABA. We call it GABA transaminase or GABA aminotransferase. And so this enzyme breaks down GABA, reduces the concentration of GABA, which may make it easy for seizures to occur. So by inhibiting the GABA transaminase, we are able to bring down the seizures. And a drug called vigabatrin is able to help us in doing that. Now, this gives us a very simple idea about how our anticonvulsants work. There are some that have not been put here because of how they work. For instance, we have not touched on sodium valproate or valproic acid because its activity, there is a wide range of systems it interacts with. It could block calcium channels, could block sodium channels. It could, in fact, also enhance GABA activity. And so it has a broad range of activities. That is why I've not put it under any of them. And when it comes to sodium valproate, it has one of the broadest spectrum of anticonvulsant activity. We've also not touched on a drug like levetiracetam. Its mechanism of action is not really known, but it has been shown that it can inhibit certain synaptic vesicular proteins, which allow for the release of certain excitatory neurotransmitters. So by inhibiting those vesicles, we bring down the release of the excitatory neurotransmitters, and that can help with suppressing the seizures. I think that this is about all time would allow us to do, but I hope to come your way again where I take a look at the individual anticonvulsants and then we address their pharmacology into details. Once again, thank you for making time to watch this video. Don't forget to subscribe to our channel. This has been Professor Kennedy Edem Kukia. Bye for now.